Roles. I'm the Senior Vice President for Clinical Risk Management for Sanford System, and I'm based out of Sioux Falls. I'm also an assistant professor at the University of South Dakota Medical School. I'm the only lawyer on the medical school staff, so I take a lot of ribbing for that. The thing I'm probably most proud of, and you'll see where this comes in, I'm also a member of the Board of Governors for the National Patient Safety Foundation, based out of Boston. And one of the things that the Safety Foundation is very involved in is simulation training, because we really feel that that not only makes medicine safer, but also kinder to the patients that come in to see us. I'm a native of Minot. I went to the University of North Dakota, got my undergraduate and law degree here. And then I practiced tax law for a while in Minneapolis, and then came back to North Dakota and eventually ran the medical arts clinic in Minot for about 15 years, and moved to Sioux Falls to run the Central Plains Clinic, and then we merged with Sioux Valley, which later became Sanford. I ran the Sanford Clinic for many years, and then about 5 years ago I had a little bit of an epiphany and thought that medicine should be about more than just numbers on a sheet and how many patients we could see during the day, and switched to risk management, because in the end it's all about the patients and how we take care of them. And I feel that safety, quality, risk are all kind of in the same order. I've known Dr. John Allen for many, many years. He and I worked together in Minot, and he asked me if I would come up and talk a little bit with you about what I could see about risk and risk management and simulation. I went, this is crazy, because this is the best thing since sliced bread. I don't know if there is any risk that goes with it. But as I looked at it a bit more, there are some topics, and we'll talk a little bit about it when I get to the end of the presentation, that there are some things that, at least when you set up a program, and even as you do things, you need to think a little bit about, and we'll get to that at the end. And we have several things I do want to talk about, and we might as well launch right into that. So where's the risk is just simulation, right? Okay. And here's what we want to talk about today. We're going to talk a little bit about the legal process, just so you know what people are looking at on the back end. We're going to talk a little bit about some of the aspects that create malpractice suits and how that focuses on communication and where that fits in with patient safety. And then finally, I always got to put a plug in for risk management, and then we'll talk about the specific things that I've ran across as related to simulation. One of the things I did provide Dr. Allen with is a bunch of source documentation, and unless you're really, really interested in that type of stuff, it's a bunch of articles that people have published on it. So I do like this thought process, and basically it's a quote on a bunch of people who are looking at higher ed and how to look at things for the future. And basically what it's saying is that part of what we should be doing in all the professions is sitting down and helping people think through things, because we're confronted with more and more complex situations all the time, and unless we have the ability to think and think on our feet, we're not going to have the capability to respond to those things on an ongoing basis. So with that in mind, here's our three topics, and let's go. I initially went into law school, and I get a kick out of this. I've had a rewarding day, 4 heart operations, 2 hips, and a kidney. You think I almost went into medicine instead of law. Unfortunately, there are attorneys, and there are attorneys in the state of North Dakota and South Dakota who think like this. They feed off the bad things that happen. And the one thing that I really, truly know and believe is that none of us in this room go to work thinking, how can I hurt a patient today? Everyone is trying absolutely as hard as they can to deliver the best possible care that they can, but things happen. I've often said in Sanford we see something like 3 million patients a year. And even if we do everything right for 99.9% of the people, that's still several hundred people a year who came in to see us and they didn't get the outcome that they hoped for. In fact, we hurt them when they came in thinking we were going to take care of them. And so in the end, it comes down to how can we change the processes, because all of us are human, And all of us are going to make a mistake no matter how hard we try every single day. And that's where you guys come in. Okay. Malpractice is defined as a failure to meet some type of standard of care of the profession that you're in. Whether it's a lawyer, I can have a standard of care for being a lawyer, whether it's a doctor or it's a paramedic, you're expected to know certain things, and you're expected to act like that when you're doing your work. So a standard of care a lot of times is defined as the skill that you have, that you're a professional, that you had a certain amount of training that went with it, that similar people in similar circumstances would act the same way, and in a courtroom, that gets to be defined by the experts that come in and tell those three items to the jury that ends up being there. Standards are also created by national organizations, particularly in the medical business. It's interesting, a lot of times they're created by state and federal statutes that say this is what we expect the standard of care to be. And then finally, for all of us who work in hospital or healthcare settings, some of the rules and regulations of the entities we work for set up what the standard of care is going to be as well. Negligence in this instance then is the failure to use the care as a reasonably prudent and careful person would do under similar circumstances. So you're not held to be the absolute best in the profession. What you're held to is what would have been reasonable for you to do in those circumstances. And unfortunately, every malpractice suit, it centers around this thing. Did they do what should have been done in this situation for somebody who knew what they were doing? Okay? Failure to use the care comes up with that. Okay? So, plaintiff's got to prove that their duty existed. I came in to see you and you were going to do something for me, that you didn't perform the way you thought you should have performed. An injury was created, and it was created by the breach that you did because you didn't follow the standard of care. So that's what malpractice is all about. Okay. This is interesting. MMIC is a malpractice insurer that insures a lot of North and South Dakota and Minnesota, at least in this region. PIAA is a large grouping of insurance companies that provide information. And what you can see is that, in general, bad things happen in the hospital more often, and that's both national and regional statistics. And then within the hospital itself, they occur in certain regions, generally in the OR, and of course when things happen in the operating room, generally it can be pretty devastating. In the ED, sometime in patient rooms, and sometimes in labor and delivery, and then spread out from there after that. If you take a look at, when you look at the allegations that come out, MMIC basically says it's improper performance of their duties. So they knew what to do and it didn't work out the way it's supposed to. Then if you get down to the bottom, some of them are mental errors, diagnosis errors. I think I know what it is and it wasn't that. Sometimes it's patients. They fell out of the bed, but what we get accused of is that you should have recognized they were a fall risk and made sure you had a low bed or did things, and most of you know better about those things than I do. And then finally, you do a wrong site or a wrong patient surgery, which would really be devastating. Okay. MMIC, and you can see I just picked up a few years to get the idea. That's normally what they pay out on average for the lawsuits that they have. Some are more, some are less. Then lawyers, that's how much they have to pay their lawyers on a claim, whether it goes anywhere or not. That's good to see. And then how many times does an allegation result in a payment? So around 22% of the time, you can see that the last year that was tracked. But it's generally in that 20s. And then who pays out the most? Now what's interesting about OBGYN, you've seen this, and those obviously are billions of dollars, I guess, when you look at it. OB doesn't have many cases, but when they do, it's pretty devastating. Internal medicine, most of the time, those are failure to diagnose cases. General surgery, some mistake was made in surgery, you know. Family practice, again, that's failure to diagnose. Orthopedic is generally procedural things. Radiology ends up being misread the films, anesthesia. They can be very devastating cases. They don't have many either, but when they give the wrong anesthesia, that people die on the table. PEDS is a failure to diagnose, and so on from there. What I found interesting was a lot of times we think of neurosurgery being way up there, but generally it's not. And I think part of what happens in neurosurgery is when you're working on somebody's brain anyway, it's a pretty bad condition, and a lot of times the prognosis gets to be pretty poor anyway. So a lot of those neurosurgery cases end up to be wrong site surgeries, particularly in back surgery. So, okay, let's look a little bit about where these come from, how lawsuits arise. So the key item what you're going to see is it's really about communication a lot of times. And where this focuses in, I look at you and we're going to talk about later, what's the key item in education? It's going to be communication. How you deal with it, how you talk with people, how you do the training is going to be a key part of the risk that goes with simulation training. Okay, first one.
Hello? This is the German Coast Guard. What are you thinking about?
Yeah, well. All right, once it gets me back up, I'll go again. I knew a guy that actually talked like that, so. This came out of the Wall Street Journal, which I think is very interesting, that you go in to see a doctor, and maybe we're all like this, that how the doctor treats you, how he talks with you, people perceive as more important than if they actually know anything. Well, obviously that can be a problem sometimes, but I do think that's interesting. Which, by the way, I have to tell you, I give some of the same talk to residents, and so you'll see some slides that are going to be directed more to physicians, but I think it'll, I apologize for that, but I think it'll be interesting for you. I think this was an interesting slide. This comes from the American Medical Association, American Bar Association, and why do patients sue? Look at the first two. That's 70% of the suits arrived because they didn't feel like the doctor treated them very well in the office. And then you combine that with a bad result, that's what creates the suits. Most of the time, it's kind of interesting. People think it has to do with financial incentives. They look at the doc as a lottery ticket. Really, very rarely involved are patients interested in dollar amounts. And then I think the bottom one is another communication issue. You come in, I recently had a scenario where the doctor was saying, well, you listen to me and you're going to be okay. Well, the reality was this patient was not going to be okay, but the patient had a much different level of expectation than they probably should have. And for what, interesting, I don't know if you know the term jousting, but basically in my business, that's where one doc tries to pin another doc. And so I'm trying to get out of it by pinning the other guy, and generally that doesn't work very well, and it gets them both in lawsuits. Okay. When you look at that 70%, take a look at those items that people that fit in with that. 32% of the people felt they were deserted or devalued by the physician. 26%, again, communication is information was very poorly delivered. And then finally, I just didn't know what they were talking about, and something bad happened, and I'm going to sue you about it. Okay. If you look at the Joint Commission that says that communication is the root cause of, number one root cause of sentinel events, and same thing with medication errors, which is a huge issue today in medicine as well. This is the issue on Joint Commission. If you take a look at it, what's the number one item on every single one of them? It's communication, how we talk with each other. We're expecting people to understand what we're saying, and it really isn't occurring. Major issue. Okay. Physicians that rate in the bottom third of patient satisfaction surveys have 110% greater risk of getting a complaint or risk management episode. And you can probably gather what a risk management episode is compared to physicians rated in the top third. Okay. Oh, I got another video here.
I should kill you on doing Saturday, so you can be able to go home tomorrow.
He's gonna be so excited.
That killed him.
The residents really like that one, I can tell you. Anyway, it's easy to see how misunderstandings occur. That's essential. Oh, I got to advance. I really like, this is a study that was a long time ago, 1997, but I found it interesting ever since. Look at the, I haven't had any doctor laugh in my office or make jokes, I have to say that, but it might be interesting. The next one I find very interesting. Ask the patients their opinions. Got them involved in their care. And you read a lot today about patient-centered care and the rest of it. Actually, that's part of what they're coming back to. Encourage patients to talk and interact. Educated patients regarding expectations. Remember that on the sheet before? Unrealistic expectations. And look at the bottom line there. Spend on average over 3 minutes more with patients during routine visits. 3 minutes makes a difference. And you're going to see that again. People get malpractice complaints, they don't return any phone calls, they're rude and refuse to listen to their patients. Okay? And then, and for a lawyer, this is really a tough slide to look at. You get down to the bottom, it's only 7% of communication is the actual words used. And lawyers whose stock and trade is flapping our gums, that's pretty depressing when most of it is visual and the tone of the voice that you're using. And look at that last one. If the hand is on the doorknob or we're not looking directly at the people, 10 seconds is all you get to make the first impression. When I give this spiel to the residents, I talk about how to sit in relationship to the patients, how to look them in the eye, how to do communication that would go with them to make it easy for them for the patients to understand you're actually talking with them and working on their care. Okay. Yeah, I got this from an educator and I can't read it, so I'll let you take a look at it. So, all right. All of us as patients, we want to be seen and heard. We're there. That may be the doctor's 20th visit for the day, but it's the most important one for me. And I think that's what we have to realize sometimes when people come to see us, that they're expecting something out of us and we need to make sure that we provide them the respect that they deserve. They want to get their questions answered. They want to feel safe in their care. They're giving their lives into our hands, and we want to make sure we treat that with everything it deserves to be respected by. And they need to feel confident that we're going to give them the care that they want on an ongoing basis. Look, this one was interesting. This came from how to communicate with a diverse population, because we're getting more and more of it even in North and South Dakota. Look at the same line that's in there that I've underlined. 3 minutes. Now, in a day and age where we're all the time we're pushed for additional production, we got to get more things done in less time, it shows you how little it takes to be effective about things and how we have to focus on making sure we're getting that done, because all the bad things can occur if we don't do it. Okay? Now, I do find this interesting, and the doctors continue to report this to me, is the fact that, one thing about the information age is that people are getting smarter. They're starting to ask questions, and sometimes they're more consumer than patients, and they have unrealistic expectations because we can cure anything. That no matter what you do to yourself, we're going to cure it in the end. Okay. I've actually had physicians tell me this has occurred, particularly with iPads and smartphones. They start looking it up and repeating back to them. And as I tell the doctors, please understand, sometimes patients will know more about a very narrow topic than you will. Why? It's something that they have, and they're going to spend a lot of time looking it up, and so they've read every article known to mankind on a topic, and you won't have all that. And so if you can get people involved in the care, it's going to be better. Otherwise, you're going to end up like this, with just trying to look into a crystal ball and trying to figure out where it's going to be at. Okay. And I always tell everybody, nothing's better than good communication, because the more the patients, the more that the other side of the communication understands what we're doing, that gives a decreased anxiety. Not only does the visit feel better to everyone involved, you get improved compliance with directions that need to be done in treatment plan, and you generally end up with better outcomes. And this is all data proven by stuff you can read. Okay, I'm not going to go through this here, but let's go to this. Some of these cases come from an unnamed large healthcare system in the Midwest, but ran across a case where a primary care doc prescribed a medicine for high blood pressure. Okay, one for increased cholesterol. They were contraindicated to the adverse reaction when they took them together. Patient didn't do very well. Renal failure, was in the hospital almost 4 months, nearly died out of it. I like the outcome here because risk management ended up talking to the patient. Patient saw no reason to make a fuss because the doctor had tried his best and had treated her with respect. Okay. So when it works, you can say that, especially in surgical teams, higher levels of communication collaboration with both the attendings and the residents decreased risk-adjusted morbidity. Things just went better the more people talked and understood what was going on. Okay. This is an actual case too. ENT sees a patient for a little ringing in the ear. They do a workup. Testing was inconclusive. Patient's complaints continue to get worse. Filed a lawsuit for failure to diagnose, and the lawsuit get dismissed when the plaintiff was unable to find an expert to testify that it was bad care. Care was good. Everything was right on this. When we interviewed the patient afterward, look at this. He treated me rudely and brusquely, walked into the exam room with a head buried in a file, didn't say hello, roughly pushed my head from side to side instead of asking me to move it, stood in the doorway with his head down writing something, and then snapped at me not to interrupt him. It was all about how they were treated. And then you had a result that didn't work out, and that's why they ended up getting sued. Okay. Let's talk a little bit about risk management now. You probably have seen the first quote from Ben Franklin. The second one is actually where Ben Franklin stole it from, and I actually like it a little bit better. John Petard was started the New York Historical Society. Prevention is better than cure. With perseverance, we will save numbers of little devils from begetting bigger ones. And that's kind of how I look at risk management. We can learn early on, we can see trends, we can find out what's happening, we can maybe prevent something from happening later that will cause problems. Okay. Risk management basically is all about identifying a risk, find out where it came from, assessing that risk, preventing it, or if it does happen, to try to mitigate the things that happen, and then make sure that you provide the education later and make sure it never happens again. And the key thing on it, if we can identify it early rather than later, the better off it is. One of my biggest projects is trying to work on a mechanism of using the vast volumes of data that comes in and seeing if we can see trends within the data before we ever get to a scenario where we actually hurt somebody and figured out we weren't doing it right. And so that's where we need to go in risk management long run. You have a role too. And you're going to see it further on when we talk in a few minutes about the simulation training. Risk prevention, okay? Well, that's for the docs, okay? If you see something come up, it's part of your role to make sure that you tell people about it. Many, many times I run into a scenario where people don't want to report something because it may make either them or someone else look bad. And then it keeps happening, and then you end up with a scenario and say, what's going on? And you find out, again, it wasn't the people involved, it was the process that we had that forced them to do something that didn't work out as well as it could. Oh, okay. Am I doing something wrong?
Nope. They're just freezing to death.
Oh, okay. Not consistent with routine operations, which has or could have resulted in an injury. And one of the things I like to find out about is, you often hear about where we have near misses, never reached the patient, never really bothered. Example, nurse goes in, pulls a medication out of a cabinet, gets to the bedside or right to the patient and finds out, gee, I got the wrong medication. Takes it back, gets a new one. A lot of times what you find out is the cabinet where they pulled it out of, is it mislabeled? Is it things that is designed incorrectly? It's designed to actually make errors rather than to make it easier to find things to get things out. Now, those are the types of things we want to know about because as Virginia Mason found out one time, which is probably their key sentinel event, was 2 items looked exactly the same. They pulled one out and injected the patient, and it ended up being some type of cleaning fluid that, well, let's put it this way, it was a bad result for the patient at the end. And things like that happen and could have been avoided, and that's why we need to do something else with that. If you look at all the, remember you start with your business, and they give all of these papers for you to sign off of to say that you knew why you're there and what you're supposed to be doing. The vast majority of the time, there's statements like that in there. You have a duty to the organization to make sure that you tell them if something has came up and something is wrong. So you need to do that. Now, for my purposes, risk management has 2 sides of it. Remember, it's to prevent things, but it's also to mitigate risk that comes up. And one of the risks is all those front-end legal things that could occur. And so when you make reports to risk management, only give the facts. If we need anything else, we'll come back. The worst thing that we can do is that people who were there speculate as to how come something happened. You never know. And I've also given talks on what happens on disclosure. That's one of my favorite topics. And sometimes we've disclosed scenarios, and it wasn't even right, but the doctor was just speculating on why he thought something happened. And if you think it's hard to tell us a bad thing happened, it's even worse to come back and say, oh, by the way, the first thing we told you really wasn't what happened. This is what happened. By the time you're done, they really don't believe you. And I've had it happen up to 2 or 3 times in a case where we have different people come in and say different things. No one knows, and then you end up with a real mess. The other thing I always say that if you're getting responses back from people, always use quotation marks. And in the legal business, what ends up happening is the fact that if there's no quotation marks, then it becomes what you think you put down. And as a good lawyer, I'll always say, well, is your memory perfect and the rest of it? If you use quotes at the time period, especially if it's close in time, basically the juries always believe that's what you heard the people say. And that can be the difference sometimes between a winner and a loser in a lawsuit. Okay. I also talk about risk mitigation. If you have an unexpected outcome, then we need to make sure you tell risk management. And sometimes it's nothing, because all of us who work in the medical business know that nothing's a guarantee. You could do the same thing to 100 people, 99 may react exactly how you expect, but one person doesn't. And sometimes we just don't know why that occurs, other than everybody's a little bit different. And then everybody has a risk management event form, so just use the one you got. Okay.
Got it? All right. Another one, just like that. All
ability of the Volkswagen Passat. He passed down something he will be grateful for. That's the power of German engineering.
I thought that was just perfect to talk about because you're the trainers. You know, if you train the people wrong, what's going to happen? And you're going to end up something like this. So now let's talk. Oh, did I go too far? No, I guess not. You know, this slide is so messy, and I can't even quite tell you how it got put together other than the fact Pascal Metrics put it together. But if you look at it, IHI, Global Trigger Tools, which is the first one, which is it takes data and tries to estimate how many times we make a mistake when people are in the hospital. And really what it says is that nationwide, if you have 100 admissions, 45 of them are going to have a mistake made in it. I've seen the stats for North and South Dakota. We're a little bit better. We're about 25. So 25% of the time we make a mistake. This is today. We make a mistake when somebody comes into the hospital. And if you think about it, that's almost staggering. And again, what is this? This is every single person absolutely trying to do their best for the patients that come in to see them, because that's built into our DNA for the people that go into healthcare. Now, what I think is interesting, and of course, with all the news about the IRS in the paper, take a look at that. You know, 140,000 mistakes, you know, about 14% of everything they do. When you call in and ask them, what should I do, they make a mistake. That give us a lot of confidence in making sure we don't get audited on. And then if you look at the other end, you got the nuclear industry and domestic airline flight fatality rates very, very low. And what do those two industries have in common? Tremendous amount of simulation, tremendous amount of training to try to avoid things to make sure that people know what they're doing. That's why I totally respect what you're doing, and I think it's just fabulous, and I just love how North Dakota has done this.
What's that about JACO on the top right?
Yep, that's JACO, yep. You know, that is, the SC is sentinel events. That's when how many absolutely things that should never happen in a year. And so they have about 14 sentinel events per, that's where you cut somebody's, the wrong leg off. And they come in to get the left leg and we do the right leg instead. That type of thing, that should just never happen. But there's still 14 of those that happen per million admissions. Okay. I love the airline baggage handling about in the middle. The only time I've had my baggage lost is I was giving a talk in Nashville, and and they lost my luggage. And that day I'd only traveled in my casual clothes, and it was kind of like this, where I kind of flew in. I was going to talk, had no time to go out and buy anything. So one of the guys was there, lends me, this was a long time ago, and some of you may recall these. He lends me his lime green leisure suit. I tell you what, that was the most embarrassing talk I've ever. I was so self-conscious. I could hardly talk for the whole time. But at least they weren't taping me. Is the only thing I could say. I never got invited back. I can tell you that either. All right, let's talk a little bit about the risk issues in simulation. And these are the ones that I've kind of come up with. Some of these are related, will relate to you guys. Some of them will not. But it all starts with the fact, if you're going to go into this program, you're going to build certain modules or simulations that you're going to do. And the simulations have to be built in such a way that they're realistic. They're going to be able to be usable. Because if it's like the Volkswagen commercial and you're training people the wrong way, you're setting yourself up for big failures to start with. So the initial vetting or deciding upon what simulations to use is a real key. And then the next thing is it needs to go through a proper approval process by the people who are involved in the profession to make sure that they agree that it is a good item. And then finally, you need to have a periodic review. And then finally, you have to have a true mimesis of the situation that's there, which basically means it has to really look like real life. So this has to be something that's going to occur. I was thinking the other day, and this had came up. Most of you know who Hospira is a huge provider of infusion machines. I guess would be the best way to say it. You know, they run the infusion bags through you, how much you get dripped into you at different times. Hospira is released that they're going to upgrade all of their equipment. And so they want to take out of service almost all legacy issues. So I'm sitting in a meeting with Sanford, and I realized we're a large entity, but came to realize that there were 6 different models that we use throughout the system, all with varying capabilities, all with slightly different designs, all with slightly different potential to deliver dosage for people to use. And I got to thinking in terms of this. As you guys drive around the state, you know, everybody's going to have slightly different equipment, slightly different processes, and then how does that fit in with trying to train people with whatever you're going to do for the simulation? And is it matching up with what they're eventually going to do? So is the simulation helping or hurting when you look at a scenario like that? You know, just something to be thought about as you go forward. Then the other thing is that as you educate, the education itself needs to be standardized. And there's lots of you in the room, and each one of us hears something different, and each one of us has slightly different interests. Each one of us may slightly emphasize something different as we're talking to different groups. And what does that mean in terms of a training scenario that's supposed to be standardized so that we can make sure we reduce errors? And then you have to make sure, I can see you have a older version than what I have, but when we're doing that, are the people who are doing the training, how do you get credentialed? And I would assume that this meeting here is part of the way to do that. You'll be tested on your knowledge, you'll be in the end, you'll come up with a certificate that says you've gone through the training and you're allowed to be a trainer out in the field. And then finally, to make sure, because the people that you're working with are adults, are we using the latest in adult training for education? Are we making sure that that the people who are on the other side are learning what needs to be done, because eventually they're going to pray. You're going to leave, and then they're going to use this on real people. They're going to practice with you, but eventually they get used on real people. The other thing, and what these start to do is, and this is where the risk management aspects for what you're doing is, we have nationwide, there's a big FDA investigation into Intuitive, which makes Da Vinci robots. Okay, and Da Vinci robots are these, fancy pieces of equipment that a lot of surgeons use, particularly in very narrow areas, because you get these little teeny instruments, and they go in, and boy, it's a big deal, and we charge lots of money to do it. What Da Vinci is getting investigated about is that they, and I'm not saying any of this is true, and I say that on camera, but what the FDA is looking at is Da Vinci may potentially have encouraged people to reduce the amount of training needed on the front end and reduce the amount of mentoring required, and actually leaned on hospitals to reduce those things. And of course, what ends up happening, you see the same thing in what you're doing, because you really do see it, is that when you come in, when you're not familiar with something, the first few times you do it, you certainly aren't as good, as proficient as you will be in the long run. And what they found, particularly in some of the high test training like that, is that the majority of complications result in about the first 50 cases. So if you've gone from practicing 20 down to 10, and you only have somebody watch you for, instead of 10 down to 5, you may set yourself up for complications. And again, the way I always look at it, these are people who came in thinking that we're going to improve their life, and we end up not doing very well by them. And so the key for you is when somebody's going to come in to see you and you're going to do training, when you approve somebody, you really do have to believe that they are proficient when they went out there. Because if not, you're potentially sending somebody out that may hurt somebody. So your approval is a tremendous key. And if there is issues, you have to be willing to document that and send it on. And then the final thing, and I didn't get a chance to ask John, and I don't know if any of the administrative people are here, do you, when you do your training, do you video everything so that people can go back and look and see what they did and learn from it? Is there a retention that goes with that, or are they destroyed at the end of, or erased, I should say, not destroyed? So one of the things that I saw in the legal, which by the way, for lawyers, you say little, write less, and destroy everything you have. So that's generally what lawyers think about. But my feeling is if there is a retention policy, you look very seriously at how long the retention policy is, because smart lawyers know if they learn their training through simulation, they're going to be coming back to the simulators to say, how were they doing? Were they any good? Did you do your job in making sure they were trained? And oh, by the way, we can see they were no darn good because it's on the video and you passed them anyway. Major risks that could potentially be there for a training program. And then finally, this isn't something that I don't know if it's existing. It has not started, but it is definitely has not started in our area to my knowledge. None of the facilities I contacted said they're doing this, but it certainly has started out in the eastern United States where they use your training as part of their credentialing and privileging processes. So if somebody applies for a position and says they can do intubations, they're going to send them down to the sim lab to make sure that they can do it. And then on a periodic basis, if they haven't done enough, they're going to send them back for retraining to do that.
Anesthesiology has a thing called MOCA, or maintenance of certification anesthesia. As part of that, they have to spend some time in a sim lab every year.
Correct. Sounds great. That is one specialty that's really worked hard on, and that's why I picked that procedure. I can see that coming in a whole variety of more. And we're talking quite a bit about the fact, particularly at Sanford with regard to this Da Vinci training, that if they haven't done a certain amount within a certain time period, that they're going to have to go back in and do more simulation training for exactly the same reasons. Because you forget, all of us forget. We don't do something, we forget it, unfortunately, much more rapidly than we probably should, but that's part of adult learning as well. And then finally, what goes with that is once it gets in there into the medical staff issues, then it becomes peer reviewable. And that's part of what goes back to those video retention. That could be potentially something that's saved, reviewed by the peer review people to see what their learning capability was, how they did things, and whether they should go forward with it. So those are the items that really come up with. Some of it relates to you, really the focus on the training and are the people learning, and you have to be honest if they are not. And if some people have to redo it, then they got to redo it, yes.
Related question, I've heard some sim centers using a quality assurance umbrella that the IMSM hospitals have that gives them some protection.
Correct.
From discoverability in court.
That's correct, and that's exactly what I would do. They make it part of the process, particularly when it gets into the hospital. I do not know how that would fit with how it's designed in North Dakota, with it being all based out of the university and not based at the individual facilities. That's something that somebody a lot smarter than I would have to come up with. But you're right, once you can get it in, covered under peer review, that's kind of a double-edged sword. It protects the things that occur, but it doesn't always make it as open as education should be and learning. So it's, like it says, it's a double-edged sword that goes with that. All right. Like I said, I was you guys are going to be lucky because I hear you need to do some more training, so I'm way ahead of schedule, but I talked about the time I thought I was supposed to. Any questions I can answer for you?
At my malpractice, okay?
Mhm.
I'm covered by my facility.
Yes.
right? So if I'm gonna go out, and I also have my own personal, but, I mean, I know you can't tell me, Deb, do this, but I'm just curious, I mean, I think we're all in here wondering, gee, what do I do? You know, am I covered? What if I tell somebody to do it this way, and that's not the proper way?
Well, I think you're absolutely right. One, I would start with the fact that all of us who work for a company are covered, probably not under a malpractice insurance, but under, what do they call it? I can't think of the name, but everybody is covered. You're doing the job you're supposed to do that you were hired for by your employer, and they cover you for doing those things, unless you do it with malice or intentional disregard of what you've been told. So as long as you're following the directions, you are. The issue isn't so much with you. If you're following the training protocols that you've been given, you're always going to be fine. You're going to be fine personally. But the people who design, approve, all that stuff on that first slide, and it doesn't really match with what the facilities you're at, those are the people that can be opened up for liability as well. It'd be the institution, but when lawyers would come back, that's what they would say. You went out, you trained people, you knew they were never going to use it, you're training, they don't have the right equipment, this was all invalid, you know, those are the type of things that can be brought up later. But I wouldn't say there's any issue for you as long as you're following what the protocols you've been given. I just wonder sometimes, like I said, you know, I don't know, and that's why I use the Hospira. You know, just in one organization have multi-models of the same thing, so you come in and you're using, hey, this is the model that's in the sim lab. Well, they don't have that. So what's that mean? I don't know. Do you switch out everything for every site that you go to? Maybe you do.
What's our best response then? And it's not, I don't know. I mean, as a lawyer, what's the response you'd like to have said?
If the people say that,
Let's say, you know, Deb, what do you think about running the strip at this rate? You know what I mean? What's my response? Why?
well, you say the protocol says,
What if you don't know what the protocol says?
well, then hopefully you travel around with books that have what your protocols are.
Then you would get a PDR.
But because we're going to be asked questions
Yeah.
that we're not going to have answers to.
Then you don't give an answer.
Yeah. In that instance, the safest thing always is to say, I don't know, I'll have someone get back to you.
No, but I'm just.
The worst thing you can do is to try to speculate or give an answer that you're not sure of.
And that's not what I'm saying. I'm not saying I never would do that. But I mean,
Yeah.
is there any way that would throw us into a,
No.
no?
No.
Give them a homework assignment.
Give them a homework. You know, that's really a great question. Why don't you come back and tell me what you think it's going to be?
Oh,
So,
Well, and you all know more sites of art thing, you know, I know this really good, or site or this book, you know.
Evans.
I don't know how Dr. Allen or the group feels about it, but SIMSD at times will take like SimMan or your Medi unit, full general man, and they'll go mobile with them and bring them into their department and actually let them use their equipment with them.
yep.
And some sites have identified a number of features that they don't know where the chest tube tray is, or
Yep.
identified some key kind of risk things that they've improved upon after the visit. So.
There's a lot of discussion at the National Patient Safety Foundation. What works best? Is a stationary sim center like this better, where you bring people in? Is it a mobile type U? Is it something that drops it right into the department, right on site, and says, do what you're going to do, and then they watch? One of the more interesting things that I saw was, just to give you an idea where some of this is going, where they actually used simulation to go back and recreate events that occurred, so they could watch people and see how they did things, and to see if that they could recreate the event that caused the harm. And that was really interesting because you could see how processes had developed, and even though the protocol was one way, people didn't follow the protocol. I don't know how often that happens. We have our way of doing it. Protocol was written 5 years ago, and we've never bothered to update it. But I can tell you what the lawyers look at. They look at the written protocol and say, you did not follow your protocol. Well, we did what, you know, you get a hard answer. What should we have done? So, yes.
Just from a legal standpoint, from my own personal use, if you have a protocol that's in place, but you know that following that protocol would hurt that patient, so you deviate from that protocol, where does that put your liability at as a provider?
Well, you know, at least in my mind.
Shorthand. I mean, obviously, I know
Yeah.
you could probably, I mean.
Did everybody hear the question? Okay. There is no doubt in my mind that if you read all the smart people in medicine who write stuff up today, protocols only really can account for about 80% of the things that we're going to do, because patients are unique. And I think what you have to do in those is to make sure you documented why you deviated based upon the facts that you were presented with. And I think at that point, because again, what are you being held to? Remember, on the front end, you're being held to being a reasonable provider in similar circumstances. So what would a reasonable person do when they came up with this happening? You know, you open somebody up and their organs are reversed. Well, you know, you still got to do the operation. Maybe that would have indicated we didn't do things right on the front end, but if your hands are in somebody's belly, you better do something about it. You know what I mean? And so you have to do something. So, yes.
I've heard kind of two different ways of looking at it. Is it beneficial to have insurance as an RN or not? Because I was told if you have it, then they may come after you liability-wise, but others say if you don't, then you're not covered. You may have to pay something later on.
Well,
Both sides.
you know, I think particularly for RNs, if there's anything that I've seen occur in my 30 years of working in management, is the acknowledgement and recognition that RNs are well trained and have the capability of acting more and more independently as they do things with patients. You know, one time it was all laid on the doctor no matter what happened, whether anybody else made a mistake or not. You're right in one fashion. When lawyers look at lawsuits, at least how I believe they look at lawsuits, is they want to, if they're going to go into a lawsuit, they want to make money off it. They want to make money for themselves and money for their patient who was injured. And so you always go after the person with the money. Sometimes, and in that instance, what you've heard is right, if you've got the insurance, that creates money. And so then you become very, valuable in dealing with that. I've seen a lot of lawsuits. I have only seen one time where they named the RN personally, and that was actually in a home health situation. So it probably was a direct patient care issue that they were acting more independently than you would in most other settings. But so the answer gets to be kind of wishy-washy, like lawyers always are. The more you act toward that independent role, the more it probably is of value to you to have the insurance. The more that you're in a directed role, probably not as important. On the other hand, the world has gotten more litigious, that's a cinch, over the last 20 years as well. And for the cost of some of those things, it's probably well worth the peace of mind that goes with it, though, too. And that'd be my ultimate answer. more than a legal answer.
One other thing the instructor challenged with was you commented that for the team here, if they observe something that a provider or nurse, EMT does that seems kind of dangerous and this person's not maybe the safest provider, that they should report that to the supervisor. But looking at the totality of simulation and like our educational methodology, it creates kind of a disconnect because we've been, well, North Dakota team has taught them that they need to protect the safety, the psychological safety of the learner when they come in. And the purpose is for formative education, meaning it's a chance for them to put their hands on things and to try to practice and work through the challenging situations, and that it's okay to make mistakes, that we just want them to feel safe and to get the experience, and that we believe in them as adult learners, that they're already credentialed to do what they're doing, and that if they make a mistake, that we'll trust each other to do our best to identify those errors and hopefully bring them out in discussion if it's part of the learning objective of the scenario. But they might do something that isn't caught, that might slip through. But I think the general view, what I understand from simulation, is that we believe they're adult learners. They're capable of kind of also viewing their performance and considering what they know, what areas maybe they need to recognize and learn more about. And you can go home and they have a responsibility themselves to pick up where they might need to put more work in. So I want to say, that's kind of my thought on the matter. If we're doing summative evaluation for competency, like in medical school, before a med student can go from third year to fourth year, we have a big test that they have to go through, and it's very precise. We have actors that come in and they have to perform exactly that way. And the students, that's summative evaluation where they must meet that threshold in order to go on. Otherwise, we hold them back. So from a legal perspective, do you think there's a difference in what I'm saying? Does it make sense?
That was a fairly long question, but I think you're right. And what I thought I was trying to say, and if I didn't make it come across, if you're going to sign off on an approval, and you mentioned the medical students, and I know how that works, then you better make sure they can pass. If you're not signing off on an approval and it's pure education, then I would use, like you said, the education techniques to go with it. I would probably talk to the learner about the mistakes that were made and what you saw. If the reason why I suggested talking to the supervisor is more on the fact that you're the relationship you need to have with the learners is different than administrative types. And so I wanted to make sure that to get the instructors out of the middle and get someone else to talk about issues like that. My concern always comes down, though, I have to tell you. I respect the learning environment and I respect the safety of people coming in to learn. My ultimate is that we're sending people out to work on real people, and real people who are coming to be helped. And if we send people out that hurt them, we have an ultimate responsibility that goes with that. And I always come down in my role on the side of the patient over any other reason. Privacy rights, anything, I come down on the side of the patient. And so that's just my function and how I look at things. So.
Might it be reasonable for the group here if they saw something that was way out of the realm of what they normally see to bring it to the attention of the director, like Dr. Allen?
Yeah, I think that's the perfect way to do it.
If the person needs a little extra help,
Yeah.
and just be real gentle about it. And they've kind of passed on information, but then Dr. Allen can be professional and handle it.
See, the reason why I brought up, and please understand, there have been no lawsuits that I could find against simulation centers. There have been no lawsuits against trainers and simulation centers. Are they possibilities? Yes. Lawyers can be very, very smart people. And then once they get the idea there's lots of simulation going on, they will start to look at those things. Because there have been lawsuits in the past against universities for training, how they've trained their people. And when you talk about the intuitive investigation, which again is not complete and it may show nothing and it may make no difference, but just the fact that the FDA is investigating how they went about training to use their equipment leads me to some thought process that we need to be very careful. And it just isn't free and open and we can do what we want and not worry about it. We actually have to think about that end result. And the end result is the patient getting hurt. So, hopefully I didn't scare you. But you gotta remember, lawyers' jobs are always to look on the negative side of things, because if it's positive, nobody ever thinks about it. If it's negative, the first thing they do is try to find somebody who did something wrong. So,
How much malpractice should we have if we do have our own person?
oh, you know, that's a good question. I don't know. You know, I used to. You know, it varies from state to state. I think if anything, the states up in this area are fairly, we don't get a lot of lawsuits. If you were in Florida, I'd say carry more. If you're in Illinois, I'd say carry more. If you're up here, I don't know if I would worry too much about it, but I think they come in about $500,000 increments. And depending on what you do, you know, some level of nursing is much higher end. If you're a home health nurse, I'd probably say more. For what you do, I'd probably say less.
The more independent you are, the more you
Yeah, correct. That's that same kind of, you know, flow diagram that would go with that. Anything else I can answer for you? You are a half hour early. I appreciate your listening. Hopefully I didn't scare the tar out of you, but it's an interesting topic, and I really admire what you do. I think you do great stuff, and I can hardly wait till I get my tour of the trucks, but I have to come after 1 o'clock because I guess you guys are going to be busy. So if you see me walking around, you know what it is. Thank you.